Good evening, everybody. I'm Jessica and I work for the Alumni Relation teams at King's, and it's my pleasure to welcome you to the first King's Expert Series event this year, which is based on the theme of Aging Well and which will showcase some of the vital research that King's are conducting in this area. During the webinar, you will have the chance to ask your own questions to the panel by just popping them in the Q&A box, and our chair will select some of these to put to the panel. This session is also being recorded, so I'd encourage you to share the video of your network afterwards. So that's all from me. Without further ado, I'd like to hand over to our chair for the evening, Joseph Casey, who is going to lead this session. Thank you.
Welcome, everyone. Fantastic to have so many people joining us from around the world, and actually just speaking with the team beforehand, I think there's been significant interest in this session, more than 600 sign-ups. Great to have so many people interested in the topic, interested in our speakers. My name's Joseph Casey. I'm Director of Partnerships and Programmes at King's Health Partners, which King's College London is one of our partner members of, alongside three NHS Foundation trusts, Guy's and St Thomas's, King's College Hospital, and South London, the Maudsley. And my job is to bring together different experts from across our partners and around the world to explore relevant topics around research, education and training, and bringing that into improving patient care both now and in the future. And what a privilege to bring together our three speakers this evening. My job is to facilitate the conversation, to ensure that as many of you as possible can pose your questions. But before we do that, perhaps I'll turn to each of our speakers to introduce themselves, and we'll start with a bit of a discussion before moving to the Q&A. So, Dr. Claire Ellis-Smith, can I ask you to introduce yourself first, please?
Thank you so much, Joseph, and thank you everybody for joining us. Very much looking forward to this event, and good morning, afternoon or evening, wherever you are. My name is Claire Ellis-Smith. I'm a lecturer in palliative care at Cicely Saunders Institute at King's. My background is as an occupational therapist working predominantly in mental health for older adults and dementia. So I've worked largely in focusing around people with older people and mental health and dementia, and how to promote meaningful activity for that population. I did an MSc in mental health service research at Institute of Psychiatry, Psychology and Neuroscience at King's, and then went on to do a PhD in palliative care at for people with dementia at Cicely Saunders Institute. And my interest now is really providing and promoting palliative care for older people and people with dementia, particularly with the focus around addressing unmet needs, both physical, psychosocial and spiritual, to improve quality of life in this population. And I'm also particularly interested in widening access to palliative care for people who traditionally haven't had access to palliative care. Thank you, and I look forward to this evening.
Claire, thank you so much. Prof. Dag Arsland, I'll hand over to you next, please.
Thank you, Joseph. Hello, everyone. Great to know that so many are interested in our topic, and we look forward to the discussion. So my name is Dag Arsland. I'm a psychiatrist. I entered the field of old age psychiatry right away when I started my career as a young doctor 30 years ago. And everyone asked, so why on earth are you doing that? And that, well, I have my reasons, and that turned out to be a very good choice, because this topic of mental health in older people has obviously become a really, really important topic. And it was not much discussed a few years ago, but now it's on everyone's mind, which is great and very, very important. And that's what we will shed light on today. So I'm a Norwegian, worked several places in Scandinavia, including in Karolinska University in Sweden, and then I moved to King's College London 6 years ago, and really love to be here. I'm at the Institute of Psychiatry, Psychology and Neuroscience at Denmark Hill, where I'm a professor and head of the Department of Old Age Psychiatry, and also a medical doctor in the mental health for older adults, running a memory clinic, a digital remote memory clinic, which we are also quite proud of. So I spend my days seeing patients and also doing research, and we have a wide portfolio of research and covering a lot of dementia relevant topics, from basic research with animals to try and understand mechanisms, identifying new medicines, but also working with patients and improving quality of life, as we heard Claire wanted to do, in care homes even, and also we really like to want to combine the basic science with the clinical work, what we call translational research. That's what we really want to do, and also to identify new therapies. And finally, we've moved more and more focus on risk factors and prevention of dementia. And I'm sure we can get back to that during the discussion today. And that's it for me.
Thank you so much. And I'm sure I speak for everyone in this call when I say we're looking forward to exploring your reasons further over the next hour. And finally, Prof. Claire Steeves, can I ask you to introduce yourself, please?
Hello there. I'm Professor Claire Steeves, a professor in ageing and health, but also a consultant geriatrician. And today here you can see that I'm still in my memory clinic setup where I've been seeing patients with memory problems. But these are individuals that have memory problems alongside other comorbidities, which often co-occur with aging. People don't often have one thing going wrong. They often have multiple, and they all interact together. And in fact, that's one of the reasons why I was so interested to become a clinician looking after older people, in dealing with all of those complex intersecting problems, and as well as the interactions with their own families, their own wider societies. So after a while, though, having worked as a clinician, I was increasingly struck by the phenomenon of frailty, which is where somebody becomes so vulnerable to stressors that something really quite small can really knock them for six, so that they end up in hospital, and then a cascade of things happen to them. And so I was really interested in trying to understand how frailty develops, because it's not so much a single disease. It's maybe a constellation of changes in physiology that occur over age, and some of them co-occur, interestingly, together. So I wanted to understand why that happens. So I then took a step out and did a PhD in epidemiology, looking at cognitive aging in relationship with physical dysfunction. And then since then, I've gone on to do a lot of work looking at different determinants of frailty and how we might detect it early and what we might be able to do to change it.
Claire, thanks so much. And perhaps staying with you as you've started to anticipate my first question, I suppose we're really interested in this session in aging well and the kind of importance of aging health. Interested in your perspective on why that's such an important question for us as a society. Yes, here in the UK, but kind of thinking about participants joining from around the world, why this is something that we're all so interested in. I can see we've got more than 200 people joining us now, so clearly a topic of global relevance as well. Interesting your perspectives on that, and then I'll turn to each of our panelists.
Yes, thank you. I mean, I think the COVID pandemic was an interesting example of why it is that we need to really think about the resilience of our older populations. Because in the COVID pandemic, really very early on, we realized that older people get sick quicker and are more likely to die and have long consequences, including things like long COVID, actually. So now that's just one example. COVID is a stressor that happens to intervene in a person's life, and sometimes can be the thing which tips them over the edge. But not every older person is as susceptible to such stressors. And of course, in COVID, it depended on how serious the infection was to start with. But some individuals seem to be much more robust than others. So if we can understand what makes some individuals more robust, we can use that information to try to help others become similarly robust. That's the hope. And in fact, we do now know there's quite a few ways of going about it. I'm sure the audience has got some ideas. But in particular, methods to increase resilience is all about how we then can gain aging well in our society, increase our health span, so that we can continue to live productive lives into very old age.
Thank you. And just briefly, that last point about health span, for anyone who doesn't know, just if you could offer a brief definition for people joining us on the call.
Yeah, so we all know that over the last century, I guess, we've had an increase in lifespan, which has been an amazing clinical advance, partly because of the ability to treat disease. But unfortunately, what we've not seen is that health span is kept in sway with that. So what that means is that while we live longer, we have a substantial period of time at the end of our lives where we have functional difficulties, maybe need help from others, have pain, have other consequences of this process of frailty development that I've talked about. And that means that we're not able to live fully functionally at the end of life. And in fact, on average, I think it's 16 years of a man's life, 19 years of a woman's life, where they live with functional disability. And in fact, we see that that's not equally, that sort of like a burden, as it were, of functional disability is not shared equally across all older adults. For example, in people that have high socioeconomic status, high advantage, we see that actually they don't live so long in a state with some functional limitation. Whereas in individuals that come from disadvantage, have structural disadvantages, we see even longer than that. So this is something that's unequal within our society. It's affecting the end of life. It really affects quality of life. And it's something that we think we can do something about, because not everybody suffers from it.
Thank you. And I'm sure we'll return to that theme of what can we do, and indeed, what can we do in terms of the work that's happening at King's. Dag, in your introduction, you mentioned a number of different health systems you worked in across Europe. I suppose, building on Claire's response there, interested in your perspectives on the question about the importance of this field to society as a whole, but I suppose particularly your perspective across different European health systems.
Yeah, thank you. So yes, obviously, aging is becoming let's say a topic, not necessarily not a problem, but a topic, not only in the Western world, but in globally. I think that's an important perspective. So although I've had my work in Europe, I also interact a lot with colleagues around the world. And this morning I had a meeting with dementia researcher colleague from Nigeria, where they have set up the African Dementia Consortium. So the thing is that aging and age-related diseases, functional impairment, as Claire mentioned, is then a major challenge for all countries in the world. And obviously we have our challenges, but many countries have then much less resources and much less developed healthcare systems to really help older people. So that's it's a challenge for us, but it's hugely more of a challenge for many other countries. So I think it's a global problem, but the opportunities to tackle them are uneven, as we heard, the uneven distribution of functional impairment that Claire mentioned. Still, there's a lot of challenges here in the UK, and I think, well, why is this important? And I think Claire rightly said that yes, we have a number of people living longer, and that's for many reasons, including the great work of my colleagues in cardiology and cancer treatment. So this is fantastic. But then we have the challenge with these older bodies and their brains that tend to kind of develop age-related diseases, and that's then a big challenge. I think for many people, memory impairment and dementia might be one of the absolute biggest, let's say, challenges or fears with living longer, right? Yes, I would like to live longer, but not with dementia, right? So how can we cope with that? And that's not easy, but that's something we will discuss. Is it possible to influence the risk for dementia? And the answer is very briefly, yes, it is. But obviously that's not easy, but that's something we can probably discuss in more detail later on.
Yeah, thank you, Doug. And I can see already actually questions coming in on the Q&A. So do please start posting your questions for our panelists as we start to explore this conversation. And Claire Ellis-Smith, turning to you, I suppose first your perspectives on that first question around the importance of this, including thinking about your work within the Cicely Saunders Institute for Palliative Care, but also building on the point Claire made around, and there are things we can do about it. Really interesting your perspectives around the research that you and colleagues are doing at King's in this field and the contributions that are being made both locally and globally.
Yeah, I'd like to reiterate what both Dag and Claire have said already about how people living longer, there's higher dependency, and living with multiple conditions. And I think the real impact on that is when people are living with multiple conditions, they also have higher symptoms and concerns, both physical, psychological, and spiritual. And this is a global problem. Globally, we know that health-related suffering is increasing, and that the biggest increase is going to be amongst people 70 years and over. So I think we do have an ethical requirement and responsibility to ensure that we address these needs and we ensure that people don't die or live and die with serious health-related suffering. And we do need to think about, with the huge numbers of people and population who are growing older and living with these high needs, how we develop services that can equitably address needs. And as Claire has already mentioned, that we know that there are inequities amongst certain groups, and we need to develop those services that equitably address those needs. And I think that's really, really challenging, because it's also about identifying who has those needs, and then how do we deliver services around that can be delivered to scale and globally.
Yeah, thank you, Claire. And in terms of, completely agree. And in terms of, I suppose, not just understanding those different dimensions of equity and how to deliver those equitable services, how is the research that you and colleagues doing contributing to our understanding of what it takes, I suppose, to take theory and implement that in practice, obviously locally, but also then, as you've just said, with global relevance as well. And then I'll bring Doug and then Claire back in on that question.
So there's a lot about how we widen access, and I'll talk particularly about palliative care, because, as you said, that's what we're doing in Cicely Saunders Institute, is about widening access to palliative care for all groups. And so that's also understanding about what the needs are of specific groups, but then ensuring that any services that we develop and deliver consider what palliative care needs are, and consider how they reach services that are traditionally underserved. So when we're developing interventions, we work a lot with PPI groups and communities to inform what services should look like, reaching out really to the public in terms of understanding how our services can be delivered and that can be reached by more people. And then kind of working more widely with diverse populations. We also do a lot of global work, so we work and have a lot of collaborative work across the world in terms of how we deliver services more globally, and understanding particularly how services can be developed in low and middle income countries where there are fewer resources. So that's a lot of the work we do, is widening access in terms of demographics, but also in terms of wider disease groups where palliative care has traditionally been more cancer. We're now looking at improving palliative care to much wider disease groups, and also ensuring that palliative care is not provided right towards the end of life, but that actually it's provided on a needs-based, responsive way.
Yeah, thank you, Claire. And Dag, I can see you've come off mute in anticipation to kind of build on that. So I'll invite you in a moment to kind of add your own thoughts. I suppose just doing your point around PPI, for anyone who doesn't know that acronym, that's patient and public involvement. Actually, one of the real strengths within the Institute of Psychiatry, Psychology and Neurosciences in server user research. Dag, kind of building on both that, but also kind of reflecting on the strengths across King's and the contributions to this field. Interested in your perspectives before I bring Claire in as well.
Yes, thank you. And yes, I think this is a hugely important area. And it just occurred to me the discrepancy between my clinical work, where I was sitting in Southeast London and seeing patients actually from all over the world, with all languages, all colors. But then when I turned to research to see, so how can we, what do we know about this? That's all white. Every dementia or brain disease research includes like 98% white people, and usually with high education and high socioeconomic status. So that is obviously an important group to study, but then it's also important to study other groups, and there might be differences in the presentation of the disease, and more importantly, how best to diagnose and how to help people from different backgrounds. And I think the only way to address that question is to involve these groups in research. That's easy said, but it's not as easily done, because there's a disparity there who volunteers for research. So we need to proactively go out, and that's what we are doing. We have something called care group, which is run by researchers from different backgrounds. They are then going out into communities, discussing with in mosques or all kinds of different community places where people gather and talk about aging, talk about dementia. That dementia is not a normal path of aging, for example, which is new to some people, and that kind of information and then recommendation, join our research and learn more. That has led to a good group of people with very diverse backgrounds. And also my good colleagues in the movement disorders and Parkinson's disease, Prof. Ray Chowdhury has done fantastic work in that, and one of the largest non-white group with Parkinson's disease. So I think King's has really spearheaded this work, and it should, because we have really a ethnically and socioeconomically diverse community that we are serving. So it should be, but it's also, I think, clear that we do that really, really well, and we want to continue that. And I think we've done a lot, but there's a lot more to do as well, and we are working on that.
Yeah, thank you. And actually, Prof, as you mentioned, Prof. Chowdhury recently published with colleagues the King's model for increasing participation in research across a range of different groups, which both provides, I suppose, Claire Steeves, to your point, we can do something, but also, Dag, to that point there, the challenge of there's much more we could and should be doing. Claire, interested in your perspectives both on that question, but also, I suppose, taking your prompt around, we can do something, where you see anticipate the major breakthroughs in aging health over the next few years, I suppose, building on that rich research base, both across King's, but again, in our international collaborations around the world.
Yeah, really good. Thank you so much. Well, just before I go on to sort of where I think breakthroughs are, participation in research has been really revolutionized by two things that we can do now, actually. One is we've worked out much better how to interact with people remotely so that they can be involved in studies without the big sort of like step of coming up into clinics. And I think that's actually really important for engagement of older people. And we managed to learn to do that through the COVID pandemic, partly because we shifted some of our clinical services, but also our research to being more remote, which allows people more flexibility because they can participate from their own home with their friends and carers around. They can also do tests in their own environment. We can support that with nurses going to visit if needed, but we can do studies on a large scale without actually bringing them up. And this is something which has always been a big barrier for older people to be involved in research. So I think that's really good. And the second thing is that the older population becoming more and more digitized. Obviously, there is still a digital divide with older people having less access to digital services. And of course, that's not necessarily equitably distributed across all social groups. But nevertheless, all social groups now are getting smartphones, even in countries that are much below income than the UK. That is the case. And that gives us an ability to actually interface directly with patients using app-based technology. So I think there's good sort of like abilities to use these technologies to enhance participation in research, but we do need to make sure that digital divide doesn't increase any inequalities in the research we do. So that's one bit about that. I just wanted to bring that point. But I was really excited about thinking about where do the new breakthroughs come, and I want to talk about 4 different sort of sectors of where breakthroughs are going to come. The first is in actually understanding biology of aging, and I think this is really important. It's a bit dry, it might be a bit scientific, But it's really important because if we can understand the biology of the mechanisms underpinning changes in physiology, we can actually identify sources of new treatments. And so, for example, one example of this is our work on the microbiome, where we've identified differences in the microbiome in older people and frailer people versus less frail people. We've gone on to then test interventions and shown that they've made effect within short periods at least. And we're going to be widening that to do longer term interventions, which could actually maybe change people's immune system, people's inflammation, and change the sort of root causes of some of these causes of aging. But there are plenty of other examples, for example, senescent cells that accumulate in the body over time and can be actually removed when we encourage their apoptosis or programmed cell death. So that's a bit about biology. But then there's also stuff about lifestyle research. We really know now substantially that lifestyles can change aging and improve aging well. We know that, for example, a more plant-based diet with high carbs, high fibers, plant-based fibers, lower sort of white carbs, as it were, perhaps lower meat. We know that these are really healthy for aging well. The trouble is, what we need to know is how to encourage people to take on those diets. That's the biggest thing. And the same is with the other big hitter, is physical exercise. We know that physical exercise, it's probably the single best polypill to help aging well. And the trouble is, again, how do we encourage people to exercise more? And of course, maybe we don't need to just tell them, we need to do nudges, we need to ensure our environments are well designed to enable people to keep physically active, even if they have disability. And so that comes on to the next thing, which is about environments. And so I really think this is really important. In the UK, we're actually one of the most vulnerable going forward in the next few years around heat stress. Last year, in the big heat waves, people over 70 were the ones that died in excess numbers over those heat wave periods. And that's because they're more vulnerable to heat stress. You know, we need to know more about how to deal with our homes to insulate them, also work out where hotspots are in local areas, work out how we change our infrastructure of our environments to make sure that we're encouraging environments which are healthy for people to live in, especially in the context of climate change. But you know, the climate is one example of that. But there are lots of environmental things that we can do. So I think that's my third of the three. But the fourth is really where Claire was talking about better pathways to manage health when people do become frail or unwell. And that means really good use of advanced care planning and use of the palliative care service much earlier in the pathway, so people can really plan their futures much more and be frank about the futures that they might have and make decisions in time, ahead of time. But also we're really interested here in Guy's and St Thomas's in particular, but also King's College Hospital and KCL in developing really clever strategies to optimize people's health. For example, if they undergo the stress of surgery or oncological treatment, how can we actually optimize the rest of their medicine around them so that they get through that quickly? And we've done some really stellar work within GSTT in particular in working out services which are innovative to look after those people as they go through those stresses. And finally, a little bit more about the at-home thing. I started with talking about remote stuff, but also clinical care. If we can deliver that more at home, that probably is better for people. There's research we need to do about how to deliver that efficiently. But I think, you know, moving away from hospital environments and treating people in their own homes is going to be one of the key things we need to do in the future.
Claire, thank you so much. And actually, your final point starts to anticipate the question I was about to pose to Dag, but it builds actually on questions that have started to come through in the Q&A already, both from Nazreen and from Rose. So I suppose, Dag, overall, kind of interested in your perspectives on those major breakthroughs, but particularly around what we can do to prevent dementia. And you told me before this call started that was a nice, straightforward question that you were looking forward to answering. And in the Q&A, people are keen to understand where you see research heading in terms of understanding the development of dementia and whether we're seeing an increase in incidence of dementia, not only due to kind of changes in population structure, but also in relation to kind of some of the different risk factors that Claire was setting out there. Dag. nice and straightforward for you.
Thank you. That was a handful, but let's start. So challenges or the breakthroughs. I fully agree with what Claire and Claire both have said and what's important. However, I also want to pay credit to our colleague researchers also in the drug development and drug trial work, because I mean, as I said, I've been in this business for many years, and we've always talked about, oh, in 5 or 10 years we will have drugs that can influence the progression of Alzheimer's disease, but it never happened. So we always were asked that, yeah, well, you said 5 years, we said that for 5 years ago also, still you say 5 years, but now we have it. So I think that is a huge breakthrough. We have now drugs which can reduce the progression of Alzheimer's disease, period. That then doesn't mean problem is solved, because it's only a small change. It's a small change in the slope, in the rate of progression, rate of worsening. So people still get worse, but at a slower rate than without it. But to me, it's a huge step because it's the first time it has been shown. So to me, that is a paradigm shift. So we have new drugs against Alzheimer's disease. We hope they can be approved in Europe this year. There'll be a big discussion who's going to pay, because they are expensive. They've started, they're introduced in the US. So it doesn't mean it's not uncomplicated. We can always discuss, is it worth it, etc., etc. But the mere fact that we have medicines that can slow Alzheimer's disease, I think, is hugely important. And it's also important because it triggers new research, more activity, more interest from other drug companies, smaller and bigger. So it is possible, which is, I think is hugely important. So another breakthrough is in terms of diagnostics. So we've been, until today, the only way of making a really robust diagnosis of Alzheimer's disease is to either do a very expensive and not widely available imaging called amyloid or PET, positron emission tomography, which is available but very expensive and not part of NHS and very few other healthcare systems, or doing a lumbar puncture and take out cerebrospinal fluid which surrounds the brain and in the back, and pull out some a little bit of that fluid, analyze it, and you can say this person has Alzheimer's disease in the brain, yes or no. That is an invasive procedure. It is not quite as bad as it sounds when I tell it to you, because it is a routine procedure, not dangerous, but it's still a threshold. And for some reason, UK is really, really lagging behind other countries in Europe. For when I said I was in Karolinska, every person coming to the Karolinska Memory Clinic had a lumbar puncture as part of the workup. Here in the UK, for some reason, it's less than 0.1%. So it's not happening. But the good thing is that we now have had the research, including from King's and REPPN, showing that we can measure Alzheimer's disease changes in the blood. So that's a huge progress. So we can now, we are very close to having this implemented in the clinic, to have a blood-based test of Alzheimer's disease. And I think that is also a big step forward, because we need to know what is going on in the brains of people who have memory problems and dementia. It's not enough to say, oh, you have memory problems, you have dementia. That's not a diagnosis. That's just a statement. You have memory problems. You have to know what's going on in the brain. As Claire said, we need to understand the biology underlying it. If we are to treat and help people, we need to know what's going on in order to approach that pathology. And that's why diagnosis is important. And now we can do this with a simple blood test. And to me, that is, both of these two are really huge breakthroughs that has happened during the last few years. So, I mean, that is reason to be really optimistic. So we had these breakthroughs. Maybe in 5 years, there'll be other fantastic breakthroughs. So if you invite us back in 5 years, Joseph, I'm sure we have more exciting things to tell you.
I'll make sure to put it in our diaries now. And it's Claire Ellis-Smith. So we've been talking about aging well, and really interested in your perspectives around that, including the breakthroughs that you anticipate. But perhaps I could stretch that to think about dying well as well, and your perspectives on that from a palliative care perspective, and then trying to layer in a question from Thomas in the Q&A, thinking about the global collaborations that I know you have within the Cicely Saunders Institute. What are some of the things that we in the Western world can learn about health span, healthy aging, palliative care from the rest of the world? And Dag and Claire, Steves, I'll come to you on that question as well, because you've both alluded to it in some of your responses. But first, Claire Ellis-Smith, I'll hand over to you.
Thank you. So I'll start with the breakthroughs, and particularly pertaining to palliative care. And I think one of the most important changes that is happening and rapidly changing is the provision of digital technologies to support access. So, for example, work that we're doing is developing a palliative dementia intervention to support palliative care for people with dementia living in the community, which is app-delivered. And it really empowers people to monitor their own symptoms and concerns and then access healthcare providers or provide and share information. So I think the digital technology is going to make palliative care services far more widely available and help people and empower people to manage and monitor their own symptoms. And I think if we can really enhance the use and of digital interventions, we can go a long way in providing more equitable palliative care provision, particularly for people who aren't able to come to services or places as well. I think that's really important for an aging population. Obviously, always bearing in mind that we don't want to increase discrepancies because some people have poorer internet access or poorer digital access. But I think that's going to change, and we're rapidly going to better understand how that can be more widely provided. And then I think kind of the other things that may be, and that this is very new and very growing, but there possibly are opportunities for AI in terms of kind of providing palliative care interventions. But these are quite early, and I think that kind of might be ways that we can better understand how to better provide services for people, particularly addressing inequalities. So I think those are potentials, but very, very early days yet. So I'm thinking kind of more further into the future of that. And then the second part of your question was about global working. Is that correct?
Yeah. So the question from Thomas in the Q&A was, what are some of the things that we in the Western world can learn about health span and healthy aging from the rest of the world? You may kind of want to reflect on that from a palliative care perspective as well, and just thoughtful for some of the work, for example, of Prof. Prashant Jha at King's College London in frugal innovation as just one example of work across King's faculties, where I suppose challenging to perhaps be a little simplistic, that kind of simplistic model of kind of exporting our knowledge rather than, as each of you kind of already suggested, we should be learning from those global collaborations, and indeed particularly in the context of the UK, again picking up some of the points across the panel discussion. So first to Claire, and then to Dag on that question.
Is that me, Claire, first?
That is you, Claire, first, sorry.
I think that's a really good point. And certainly from a palliative care world, we definitely have had learning, global learning from particularly our African partners in terms of providing palliative care and pediatric palliative care as well. So, for example, our colleagues have developed a pediatric palliative care outcome measure that we've learned from and developed that work further. So I think there are real partnerships in really learning how palliative care can be provided across the world, and different service delivery models. I think also really, really important in understanding where kind of services have developed where there are kind of fewer resources, and how we can think about learning about that too. And for example, self-management interventions are particularly popular in terms of kind of how can we enable people to self-manage long-term or chronic conditions, and learning particularly about that from low and middle income countries. So I think there's definitely we already are doing it, and I think that will be ongoing, and that's the importance of developing global partnerships.
Yeah, thank you. Claire Steves, from your perspective.
Well, really, really interesting. Very excitingly, we were awarded recently a grant to look at the development of dynamic resilience. And this was from the Welcome Leap Consortium, which is basically a really big funder. And what's really interesting about that project is that 13 different partners from across the world were awarded sort of work together. And so that means people from Karolinska, where Doug comes from, but also from Japan, from Kenya, from the United States, all of these researchers working on, how do we become more resilient in age, all together across the globe. So it's going to be a really exciting partnership. We've already met a couple of times. We're going to meet together in person in March. It's going to be a really fruitful collaboration that's going to go on over the next 3 years. And I'm particularly interested in our Japanese collaborators who are doing a study really looking at centenarians that are living super well in Japan. And so this example is an example of, for example, in Japan, many of you will know the life expectancy is quite substantially higher than it is here. There are a number of differences in diet and physical activity and, for example, obesity, which might be driving that. There are also potentially some genetic factors, although they're probably quite small. So we're going to be very interested in finding out from them, how does the place that's possibly best in the world at living a long health span, how do they do it? There are many other examples like that, but we're going to be really interested in learning from our international partners on this.
Thanks, Claire. And Dag, from your perspective.
Well, thank you. I'm not sure I have very good examples of exactly that learning, but I'm sure there are some. But if I think about it, I think one area where there is something to learn is in the topic of, let's say, what we call ageism, the tendency to, in a Western society, to look down at older people for a variety of reasons. They don't look as well as I did. They don't drive as well as I did. I don't function as well. All these kind of things, which tending towards discrimination, whereas at least historically that was different in other parts of the world, with a great admiration of the older people. Now I think that is all these things are changing, and I think there's also changing in the attitudes towards older people, also in other countries, other parts of the world, adopting kind of Western style. So as the same way as I tend to adopt the Western style and Western lifestyle in terms of diet and reduced physical activity. So in a sense, we have a negative learning of our not so healthy cultures or lifestyles to the rest of the world, which is not so good. So to me, it's more like that we work together and try to approach the major problems together. There is definitely something to learn from each of us, but also if we work together, we are much stronger, and we can use our resources and the expertises more efficiently. I think that is, to me, the main thing. And I'm involved in many international global networks, and I think it's amazing. And it's also amazing in terms of the opportunity to have exchange of young researchers coming, traveling this way or that way, and to see how things are done at other places. I think that's extremely valuable. That said, I wonder, Joseph, you asked me earlier that I didn't answer that the prevention of dementia topic, and I also partly consciously wanted to not address that, wanted to save that to the end to ensure that people don't leave us before we stop, or whether you want to get back to that a little bit later on.
Yeah, noted. I will make sure that I chair us to time. So very nice prompting there back to me, Doug. I'm going to stay with you. I'm going to ask you a difficult question, not just because you've prompted me there. So this is combining questions from both Jazz and Peter in the Q&A. So the kind of first is the optimal age going up? And I suppose linked to that, what are the early signs of frailty, and when should people start seeking kind of skilled help? I suppose as kind of support from different expertise. And I'll allow you to define that, Dag, as you think helpful, and then I'll turn to each of kind of Claire Ellis-Smith and then Claire Steeves on that, and then move on to a question from Andy in relation to remote communication. But Dag, first to you on that question of, is there an optimal age? If so, do you think it's going up? And what are some of those early signs of frailty that people might want to be seeking expert support on?
Yeah, thank you. I was just wondering whether the question coming from someone following the American elections for presidency. You would hope that the optimal age is increasing when you look around you. It might be, but maybe not that rapidly as the kind of the demographic changes in the people governing the world. Anyway, to be serious, I think in general, cognitive or mental intellectual functioning with age is a very important and very complicated question, and there are some general aspects there. So and a lot of these functions, unfortunately, for those of us who have reached 50 and 60, most of these are going down. And so particularly those related to speed, mental speed. So you might have noticed when I talk is much slower than Claire, but that's how it works. But then there are also some positives. So there are some elements which improve with age, and the wisdom and the experience. Those kind of factors also are engraved in the brain and help us, let's say, increase and improve our mental capacity while we live, if we are lucky and not have a disease affecting the brain. So I think it is a mixed picture. And when we talk about whether this optimal age is increasing, I think in general, I think there are at least arguments that is the case, in the sense that people tend to they live longer, but they all stay healthy longer, at least many groups in society, right, Claire? And in Norway, we have many people running not only marathon, but also cross-country skiing, like over 3 days. And we have a number of older people doing that kind of stuff. And you might wonder, is that a good sign of intellectual wisdom? Maybe not, but it is a sign of the body is working. And when the body is healthy, the brain is also healthy, because we know that what is good for the body, what's good for the brain, is for the heart is also good for the brain. So it's all linked together. That's why Claire and I like to work together, because me coming from the psychiatry and brain focus, and Claire coming from the rest of the body, it's all mixed together, and we need to take care of both elements. So in that perspective, that our physical health is improving and mental health is also improving, cognition is improving, I think the optimal age is probably increasing. I don't know whether there's a cutoff there. I think we can say that it's hugely individual, right? I think, and that's one of the elements with aging, that well, we have an average, but around that average, the variation is increasing. So that is, I think, my take on that interesting question.
Thank you. And actually, Claire Ellis-Smith, I'm going to try and build on that point, taking Dag's point about it is individual, but notwithstanding that, and this is a question made from Anastasia, interested in your perspective on what are the kind of mental health and cognitive factors of development that are supportive of preventing dementia. So the examples given in the question around learning languages, for example, and there's been a number of kind of more specific questions in the chat as well about the role of getting out into nature, for example, and socializing. And Claire Steeves, I'll then come on to you on that question in relation to remote communication. But first to Claire Ellis-Smith. The Claire's is definitely testing my mental dexterity, so good for my personal aging.
Yeah, sorry about that. I think for me, I don't have all that much to add, although I would say, particularly in relation to the body, but also the mind and mental health, unfortunately, there are big discrepancies in society, and I think some populations or some groups in the population have different outcomes in terms of aging, and I think that's a real problem, because that's about opportunities they have. It's about lifestyle related to their opportunities. So I think there are kind of problems around that, in terms of some people have better outcomes than others, and some people have probably better aging trajectories than others. So my worry is, and I think what we really do need to look at, and it's not my area, but I do think we need to look at kind of what Claire was saying about kind of lifestyle and environment, and how we make this equitable across populations.
Yeah, thank you, Claire. And so Claire, this is a question. Claire Steves, this is a question from Andy that kind of builds on that around. So a lot of discussion around digital technologies, the benefits of increased access to remote communication. But a question to you about, is this a double-edged sword in terms of potentially discouraging people or displacing activities that might involve the examples given, getting out into nature, socializing with other people? Interested in your views and perspectives on that. And then I've got a quite specific question around protein that I'll come to you on as well.
Gosh, very interesting. Well, I think this whole issue about sort of remote versus, do we, if we operated in a virtual space, would this be good or bad for our aging? And I think it's pretty clear that we need physical fitness for as we've discussed, around physical fitness being a key driver of aging, but also social interactions are really important in terms of driving health and quality of life as well. So definitely, when we're talking about remote stuff, we're talking about using them wisely. And but they, if we go fully remote, that's not going to be very good. And that kind of brings us to a sort of an idea which has sort of cropped up in some of the discussion here, that of course the aging that we see sort of within the population that is older, it is a consequence of what's happened to them over their whole life, which starts a long way further behind. So we know that, say, for example, that there's a big difference between people who went through the Great Depression versus people who are the baby boomers. It's going to be really interesting. Now we're seeing in the US, for example, that people are not living quite so long. Maybe there's a tail down in health and lifespan, which is probably because of the obesity increasing, but maybe there's other mental health factors. But it'd be interesting to see what happens around aging. And then, of course, now as we go into sort of like a digital third generation, digital tech generation, who are physically much less active, of course, that's going to have a knock-on impact on aging later on. So I think it's really interesting to think about that life course perspective when we're thinking about how to age well. And we've seen that. I study twins. I study twins that age, and we find that actually twins share an awful lot of aging parameters. And often when we look at associations between things which are across a population seem to be causal, when we look within twin pairs, they're not quite so causal. And that's probably because there are antecedents that might even be as early as in the womb, which affect the future aging much later on. So this is why when we're thinking about interventions, we really do need to think across the life course. We need to be thinking about, breastfeeding mums. We need to be thinking about physical activity in childhood. That's those social interactions we're talking about, as well as mental health across the life course, which has a lot of knock-on effects on the development of multimorbidity. I don't know whether I've answered your question in particular there, but I just wanted to bring in the life course perspective.
Absolutely. And my fear here as the chair facilitator is that I suspect we could go on speaking for at least an hour, and especially based on the number of questions that are coming in. Claire, I'll stay with you for quite a specific one around what's your current view? This is from Joyce. What's your current view about the amount of protein that should be eaten as people age to support healthy aging? And perhaps this starts to prompt our kind of closing remarks around the kind of prevention aspects that Doug has reminded me about. But Claire, first I'll kind of turn to you on that kind of specific question in relation to protein.
So thank you so much for that question, because it's a really interesting question. Lots of sources have said that, especially that work on muscle function, actually, say that older people need to eat more protein compared to younger people in order to maintain their muscle strength. And so generally the idea is that older people need to eat more than 1, possibly up to 1.3 grams of protein per kilogram that they weigh in every day, which is quite a lot of protein. So you might think that that's sort of like the only answer. We've published a recent study which shows that if you eat loads of protein, like more than that, actually you've got a worse health. And in particular, we think that that's probably because of increased consumption of meat-based food, which might not be very good for your muscle. But also crucially, if you look at the rest of the body, in particular, maybe cognition, actually high protein levels, especially high meat consumption, is probably not good. So we've got this kind of like interesting things going on, which we often have with aging, that we might have two intersecting problems, you know, different body parts needing different things, but also different processes going on. For example, the development of something called anabolic resistance, where people don't respond to the protein as much, plus dietary changes. So it gets a bit complicated. And when I'm here sitting in clinic, I'm often tempted with my very frail older adults to really advise them to eat lots of dairy and plant and meat-based plants, okay? Whereas if that person that's sitting in the clinic was coming and they were somebody who was worried about early dementia and maybe they were a bit fitter and weller, I'd be giving them the opposite advice, to actually really reduce their meat-based protein and increase their plant-based complex fibers and so on, get their protein that way. So are you with me? There's a little bit of a no one size fits all. And actually, this is something that we'd really like to research. We've had a number of attempts at getting grant funding to really get the evidence on this through big population studies, to look at actually where is the cutoff points? How can we personalize this to make the really best advice for an individual sitting in front of us?
Yeah, thank you. And I suppose building on that theme around personalized aging, there's a question from Colin in the chat, which I'm going to put to Claire Ellis-Smith. This is a big question for you to answer in about 90 seconds before I bring you on to Dag. So apologies. So understandably, these presentations, very positive, looking at, you know, the questions I've asked you, what can we do? But many of these personalized health aspects sit within the social and economic context of aging that people face, and health inequalities are often beyond the control of individuals due to those social contexts. Given that, from your perspective, thinking about the field of palliative care, what is it that we should be really focusing on to address those social contexts from a research perspective to kind of inform, I suppose, ultimately policy that is so important in this field and the context that people live? And then Dag, I'll come to you for the last 1 minute for your views on what we should be doing in relation to preventing dementia. So nice big questions with very small amounts of time. Claire, first over to you.
So just to understand, it's about understanding social context or society. I'm not quite sure what you mean.
Sorry, yeah. So we've been talking about personalized health, personalized aging, but of course, people exist in social and economic contexts which are often beyond their control. From your perspective, thinking about your work in palliative care, what should we be looking to inform, I suppose, from a policy perspective that looks to shift those contexts in which people live?
Yeah, I mean, I think from a policy perspective, I think we just need to look at widening access to support. I think we've got to understand that people can and should kind of as much as possible support themselves, but I think we do also recognize that as people age, they will probably live with multiple conditions, including dementia. And then I think we need to understand how best we can ensure that people have access to the support they need. And from a palliative care perspective, I think there's a kind of a real shift that we really need to start talking in society about approaching end of life and palliative care, and shift the narrative a little bit in terms of what palliative care is. That palliative care is not necessarily end of life care, but palliative care can benefit people early on, that we are promoting comforts and improving quality of life, and that can be provided and should be integrated alongside all other health care. So I think that's really kind of a shift we need to make in terms of integrating palliative care, having a dialogue, having a discussion about palliative care, and then moving away from prognosis to needs-based, where we really do a needs-based approach that's flexible and responsive to individual needs. So I think that's where the focus, I think, needs to shift on a more societal level.
Yeah, thank you. And Dag, with less than 30 seconds remaining. How unfair of me. I'll turn to you for that last perhaps comment on the prevention agenda in relation to dementia before we get cut off at the end.
Yes, that's a hard one, but I think I would just go back to what Claire said about diet and particular physical activity, and the key word is activity. I think all kinds of activity is good. So if you want me to say one thing, that's a good thing. And pointing at the ears and hearing ensures that you have hearing. There are a lot of things. We know a lot of risk factors, but we don't really know how we can reduce incidence. So in essence, we don't really know how to prevent dementia. That's why we all need to support dementia prevention research at King's. And Claire and I have huge plans, and I think precision intervention is the key, and that's what we want to explore. So follow our research, and I'm sure some light will come in a few years.
A fantastic call to action at the end. With a minute over, I'm very sorry. I think my kind of last job here is say a huge thank you to all of our panelists, and indeed to everyone who's joined us from around the world this morning, afternoon and evening. And finally, Jessica, I'll hand back over to you.
Thank you, Joseph. Well, what a fantastic evening this has been. Thank you very much to our panel for volunteering your time to share with us the valuable research King's is conducting in this sphere. And also thank you to our amazing audience for getting so involved and asking such interesting questions as well. I'll send a follow-up email which will share the recording of the webinar, as well as some more information on the research that King's is doing with ageing, should you wish to find out more. And there'll be a survey for you to share your feedback with us, which would be very useful. Do keep an eye out as well for more events in the King's Expert series. We upload them to the King's Expert series webpage, and we're due to do another one in December, which we'd love for you all to attend again. So with that being said, thank you again for joining us, and I hope you enjoy the rest of your evening.